So, hello everybody. It's the June the 30th in many countries, but it's already 1st of July in the half of the world, like Switzerland. We now have the 1st of July, and I say a warmly welcome to everybody to tonight's session of the Virtual Global Spine Conference. Today, it's going to be a very international session. We have got two fantastic surgeons, and I thank you to Dr. Reuben So, who is a senior consultant in Singapore, and hello to Dominique Rothenfluh, who is a surgeon from Oxford in UK on his transition to Lausanne, and both will show their complex cases. Both are being here in this conference 1 year ago, and they've shown impressive cases. And I also wanted to mention our co-hosts and panelists. I see Dr. Mike Selby. He is from Australia and said good morning because it's, I think, 8 o'clock in Australia. And today we want to start with Dr. Reuben So from Singapore, and I'm thank you for joining us in the morning. It's 6 o'clock in Singapore, and please, Reuben, if you're able to start, thank you very much for joining us.
Thanks so much, Alex, for inviting me, and for all the participants and friends whom I'm seeing on Zoom right now. A very warm welcome. I think that it's been a pleasure to be able to share these cases via such an easy platform, and also at the same time, I'm hoping that by sharing all these cases, I can sort of highlight some of the pitfalls that we face when we embark on all these kind of lateral cage placement, whether it's through the trans psoas or through the anterior to psoas kind of approach. So without further ado, I think we'll just get the presentation started. I think once more, of course, I'll just say that this is quite informal. I would say that if you have any questions you want to ask, you just type it into a chat box, and then later on, and I'll definitely try and answer these questions along the way. So let's go. So I think that, of course, we find that there are increasingly more and more patients who are undergoing lateral lumbar interbody fusion. You can see it really in across this PubMed, where you can see that so many papers are actually talking more and more about lateral surgery. And whenever you type the search function, you see that even more start appearing. I think some years ago when I was doing this talk, so a version of this talk, it was looking at like 1,500, and so that just yesterday or 2 days ago, it's 3,100. So I think you can see that when you type in these terms, and you can see that there's this bar chart at the bottom left-hand corner, that this is actually an increasing trend. And I think the increasing trend is representative of the powerful effects of deformity correction when patients will have both coronal as well as sagittal malalignment, and cages are going in to sort of really change that malalignment. And of course, when we take out the disc during the surgery, you can see actually a large chunk of this is being removed. And this also certainly helps with improving the surface area for fusion. Now,
Reuben, may I ask you, when did you do your first lateral lumbar fusion? In which year? Can you remember?
Yes, 2016.
16. And may I ask Dominique from Oxford, can you tell us when did you do your first lateral?
I think it was 14.
14. Thank you. So we are a little bit late when you see somebody started in 64.
Yeah, that's right.
Please go on, Reuben.
So Principally, I think for those who are not familiar, this is, I think, what is really trying to happen. You're inserting a lordotic cage, and then you're getting the indirect decompression for these kind of patients. And you can see that the foramen is certainly increasing in size, and certainly also you find that the interbody space, you're recreating lordosis as well. Of course, the more lordosis you need to, in order to correct, one should actually do some facet joint removal, and that will allow you to be able to compress the back of the spine better and then achieve even more. But thankfully, I think what we are sort of blessed with in Asia is that many of our patients in Singapore, many of them are like a Rusuli 1 type of picture. And so they don't really have a very large pelvic incidence. And as a result of that, we tend to not have to do too much in terms of chasing the lumbar lordosis, and therefore that allows us to sometimes not have to always, on a very consistent basis, go in and remove the facet joints to be able to compress backwards and result in getting that lumbar lordosis. So I just showed one a quick case. So this case is he decided for, it took a long time, you know. I actually spoke to him for 2 or 3 years before he decided for surgery. You can see this patient, he's probably having some adult residual scoliosis from the time he was a teen. And he was progressively having more back pain. And you can see that this curve is showing a large 50-degree curve in both the thoracic as well as the lumbar. Lumbar is almost 60 degrees. And you can see his back is almost straight. You know, there is no more lumbar lordosis. And similarly, if you don't see any lumbar lordosis, that's why he also has hypokyphosis of the thoracic spine. And I thought that if you look at it a bit closer, you can see that this patient's hypokyphosis, now in his 50s, is driving him into a slight kyphosis actually at the cervical spine. And so he was actually complaining quite a lot of neck pain. And of course, he was complaining also that every time he was walking, his claudication distance was getting shorter and shorter. So these are his bending films. You can see it's fairly stiff. And so these are his pre-op MRIs. You can see that most of the canal actually is quite patent, but you can see that some places there's a bit of lateral listhesis, like here on the left side of the L4-5, and L3-4 is also a bit of lateral canal stenosis as well. So I tend to stage these patients with anterior procedure 1 week apart from the posterior procedure. And so when we did this, I think he continued to have stayed in the hospital while waiting for stage 2. So you can see that immediately by using the lateral cages, there is a little bit of increased mobility of the spine. You can see that the lordosis is starting to be recreated on the lateral view. And also on the coronal aspect, you can see that there's some release and some improvement in the scoliosis. So of course, when you see, what is nice to know is, of course, when in this 1 week, when we are waiting for stage 2, mainly because we have a very full operating list, you find that actually when we can actually get some MRI scans, which help us determine which are good places to do the to focus our attention when it comes to doing a decompression in stage 2. So you can see that actually all you can see that there's much improved in terms of its cage. In terms of cage placement, some of them, of course, are a bit oblique, but you can see that actually they have opened up the canal quite a fair bit. And of course, after that, in stage 2, we just do a regular T4 to pelvis because of the inclusion both of the thoracic curve as well as the lumbar curve. So you can see that recreating this lumbar lordosis is a bit easier, I think, when it comes to having these anterior cages in place. Now, I must say that these big time operations don't come without their risk. And you can see that initially his pain, actually it took some time to settle down. His neurogenic symptoms certainly didn't come down so quickly. And one of the reasons really is because I think that when we deal with the front of the spine, the psoas muscle is actually a very complex muscle. Now, in the front of the psoas, you have actually the genital femoral nerve. And for a long time, this patient was complaining of groin pain. And this groin pain, actually, I think was neuropraxia of the genital femoral nerve. And that's why his happiness of his operation took some time to settle down. And it took actually maybe about 6 months before he felt a bit better. And at 2.5 years, I mean, thankfully, everything has healed up nicely. And so you can see that it took a long time to actually settle down. Although the neurogenic symptoms, as you can see from the bottom left-hand view, actually is quite quick in terms of pre to post surgery because of the effect of the decompression.
Reuben, may I ask you,
yes.
What is your post-op pain medication protocol? Do these patients need more opioids, more morphine post-op than pre-op? What is in Singapore? What is the standard in your pain medication if you have such a severe pain syndrome 1 month, 6 months later?
Okay, so I actually put them quite a lot of them in the initial post-op period on the PCA morphine. I think the morphine will come off usually around day 3 or day 4. But before it comes off, we will increase some NSAIDs for them. Usually we tend to use some naproxen as part of our NSAID strategy together with some paracetamol, which is just like a Tylenol kind of cocktail. But with regards to the neurogenic pain, I think we actually use a combination of amitriptyline as well as a bit of pregabalin, Lyrica. And I think that this helps to settle down the neurogenic or this nerve stretching or neuropraxia related symptoms, moving from that post-op period all the way to around 6 months where they finally stop taking the medication.
Okay, then it's the same here. May I ask you, can you go one slide back and you perhaps, because another one, because there was a question about the C-spine. You mentioned the C-spine pre-op. Can you tell us what is the neck pain? Did it change too?
The neck pain got better. Now, if you look at this X-ray here, I think that from slight kyphosis, his cervical spine now is in neutral. But I also recognize that perhaps when I look at this X-ray, I could do even more contouring to recreate the kyphosis in the thoracic spine. And of course now that I have the benefits of these patients, that we try a bit harder nowadays to, especially for those patients who are old patients who have suffered from scoliosis. I think it benefits us to try to give them a bit more thoracic kyphosis, which will then allow them to naturally rebalance their cervical spine. I saw quite an interesting article about this from our Nagoya group by Noriaki Kawakami back in 2 or 3 years ago in the Scoliosis Research Society. So they had this fantastic study of about 30-year, 40-year MRI follow-up of their patients who had adolescent scoliosis. And a lot of them had quite a fair bit of neck degeneration and more neck degeneration when they did not recreate the kyphosis so much. And so that was sort of like a warning instrument coming from the Nagoya group that says that, look, as we are doing all these adolescent deformity surgery, do consider making sure that you restore as much thoracic kyphosis as possible, because there is implication on what's happening in the cervical spine. Yeah.
Thank you.
Yeah, I'll just finish up the last few slides for this thing. Yeah. So anyway, he's back to work. this chap, and I'm quite happy with the outcome of this. Of course, if I was to do it again, I would probably put in a bit more thoracic kyphosis, and probably, now that I'm aware a bit more about the genitofemoral related discomfort, I will try to look a bit harder when I'm doing this operation for the genitofemoral nerve, because that took really about 6 months to settle down before he stopped complaining of that groin discomfort. So I think, when we do all these, there will always be some bit of learning curve. I thought I'll just put these main headings into approach related or implant related, so as post-surgical care. So often I find that my complications from lateral cages comes away from the deformity patients due to the rotation of the spine. So when there's rotational deformity, I find that sometimes the cage is not going in truly in the lateral plane or the medial lateral plane of this space. And sometimes that can result in not allowing me to get my goals of restoration. And sometimes, of course, if we don't do the orthogonal maneuver when it comes to doing a anterior to psoas approach, the cage can actually go in and hit the contralateral foramen. And similarly, of course, as we operate on some of these patients with older degenerative scoliosis, I found that my cage subsidence rate is a bit higher when it comes to patients with a large amount of scoliosis, because I think we are jamming the cage against the end plate. When we use a smaller cage, the 18 mm versus the 22 millimeters, there's also another risk factor for cage subsidence. And generally, I find that the patients who have a T-score with less than -2, so it doesn't even have to be -2.5 as per the diagnosis of osteoporosis, but I think -2 in itself, for me, I think as I journey on this lateral cage, I feel that some pre-surgery teriparatide is quite useful in order to strengthen the entire spine, so that we actually minimize the risk of cage subsidence.
Hey, Reuben, may I ask you, how many incisions did you do in this case? Sometimes the trajectory is good and you can make one incision, but sometimes it's hard. You did 4 laterals.
Yeah.
How many incisions?
Two incisions. Yeah.
Okay.
So one for the A-lift, which is done in a lateral position, and then one more for the 2 to 5.
Okay.
Yeah. So I just show some of my patients who have inappropriate placement. You can see that some of them, you can see that my cages are too far out. Some of them, they are not so well aligned. They're a bit mal-rotated. And I think this also can occur sometimes when you push it too far back. You can actually, although you get a great amount of indirect decompression, sometimes you don't get enough lordosis restoration. And of course, sometimes this is too far back, and you end up with a problem of the disc coming into this, the interbody spacer coming into the canal. And so I've had this problem before, and you can see that there is the markers are showing the interbody spacer, and they're a little bit too close to the back. So I did a posterior decompression, and as a result of that, in order to try to create space for the foramen. So as I mentioned before, 18 mm usually get a bit more subsidence than with the 22, but sometimes we have no choice but to use the 18 because of the size of our patients. They're a bit small in nature. And of course, the longer the construct, you find that there's also a high risk of cage subsidence, and more cage subsidence when it comes to lateral plating. It's like so. Yeah. So when we look at our own cage subsidence group, I think we find that this was done some years back, we wanted to look at the X-lift versus O-lift, well, really trans-psoas versus oblique anterior psoas approach, and we found that really the risk is about the same, when it comes to this. both actually do well when it comes to giving out good outcomes for whether it's both transovers or anterior to psoas. And I think that when we look at the amount of fusion, when you do more levels, of course, then the subsidence rate certainly increases quite a fair bit. Yeah.
And what is your personal favorite, transpsoas or antipsoas?
So I think for L2, 3, and 1, 2 probably is transovers. And I look quite hard at the size of the psoas muscle when it comes to the 4, 5, because and the 3, 4. Sometimes I do transovers for 3, 4. Sometimes I do anterior to psoas for 3, 4. It really depends on the amount of size of the psoas. And of course, if we have a very high riding psoas, definitely I will try to choose an anterior to psoas approach. Or if a very bulky psoas, I'll choose an anterior psoas approach. So it's just very variable when it comes to, because every level is quite different when it comes to talking about lateral surgery. Yeah. So of course, for us, is in some ways we have a low BMI problem, and low BMI really is, you think about this is like the thin Asian female with some osteoporosis, and I think that was what we found that actually has a bit of a risk factor when it comes to dealing with cage subsidence. Yeah. So anyway, what happens is that after they subside, they actually subside and they reach a stable position. And then after that, then they still report good outcomes when it comes to their post-op patient-reported outcomes. And yeah, and so I think most of them, they will continue to always have a good outcome. And you can see here, this is actually a cage where there's been 2 posteriorly placed, right? And this patient actually had to have a direct decompression of the area to prevent iatrogenic stenosis. That was, and so these are some of the things I think are things to consider when it comes to doing these lateral cage placement. So I think I am sort of so anyway, with regards to too much anterior, you can also have problems with placing the cage too anterior. So this chap, he has a very tall disc space, and this tall disc space is actually not the best patients for starting out with lateral cage placement. And so I when I placed it in, I felt, whoa, it's going to be a tall cage that you need to deal with. And what happened was that I didn't really estimate that the listhesis actually had shifted forward. And because of the shift in the positioning, the nerve probably moved forward as well. And that's why I couldn't get a safe zone that was more central, but the safe zone had glided forward as a result of the spondylolisthesis. And so in the end, I put in a cage, and I think I damaged the anterior longitudinal ligament, and I had to put in a cage that was they can secure with a screw. And of course, it took him some time, because what happens is that when we put in cages that are, after you've damaged the ALL, you can go bigger and bigger and bigger, and you don't really have that tactile feedback anymore of that cage being sitting nicely in the interbody space. And so I think that this patient was oversized, and he had a lot of back pain for a long time because of the oversizing of the disc space. And immediately, for those who do single level fusion, this guy had a very, you can see that he has a bit of iatrogenic reduction of his disc height, both at the L5S1 as well as the L3-4, due to too much distraction. And so I think these are some of the cases that I think we highlights the need to be very careful when it comes to dealing with such an anterior cage placement. Okay, so really, I think I probably, in retrospect, have learned a few things over the years. Recognize incorrect placement early, and if you need to, you have to stage the surgery. Obtain interim scans if you have to. And when it comes to scoliosis, now, and on every placement of every cage, I have to readjust the patient because I recognize that they will derotate as you put in a cage more distally, and as you go more proximally, it will change the rotation. But I tend to start actually with 4-5, and then I will jump to L2-3 because I don't want to have do a 3-4 and then having the 2-3 pushed under the ribs. And so my choice of cage placement nowadays is to try to aim to have it all done within the same incision. But in order to do that, we have to sort of do the lowest, the highest, and then lastly the in-between guy as we are doing this multi-level surgery. And for me, and especially for our patients who are the small, wizened type of patients with low BMI, I'm actually always very worried about their cage subsidence. So these patients do a pre-op BMD and also do start them on teriparatide to help to avoid the cage subsidence. So of course, my tips, of course, ensure a true AP. As always, the endotomy site is actually the cage location. I try my best to stay less than 25 minutes per disectomy. I always reverse the way we are doing the pituitary so that I don't cause an iatrogenic dural injury as I'm doing anterior to psoas. I spend some time standing looking at the MRIs, and in the X-rays, if there are a lot of rotation, I always call for angle instruments, which sometimes need you to pre-tell the theater in time so that they can bring in the extra trays. I would not overstaff, and in severe central stenosis, please do consider a direct decompression. Right, thanks.
Oh, thank you, Reuben. Thank you. This is very interesting cases, and thank you for sharing your experience in this technique. I think we all hear a lot of lateral approaches in different positions, prone positions. Dr. Gargano from our panelists asked what to do with the anterior ligament, as you mentioned. May I ask you, do you think that in your experience, all Titan cages are better than the PEEK ones? In the beginning, we all used PEEK ones, and now many companies switch to all titanium for good reasons. Do you think you will change too, or will you stick to your well-known implants?
So I've been using the titanium implants maybe only the last year and a half or so. I actually want to see a bit more follow-up before I commit to an answer. But in the initial phase, I have found that the subsidence is a bit less because I think of the way the cage is shaped. It's quite a different shape compared to the PEEK cages, less teeth. And I think these teeth sometimes can cause a little bit of damage to the end plate, particularly if we only insert it with a slider that is not deep enough to take the entire depth of this space as the cage is going in. But my concern about the titanium cages is I'm not sure how to look for fusion in the follow-up if I do a CT scan, because I see a scatter everywhere. And I find that probably the usage of the flexion extension view is probably even more important now that we can't really see the fusion so clearly through the metal cage when we do a CT scan.
Yeah, still, this is so true. The metal is looking good on X-ray, but we can't verify fusion. You showed impressive cages, multi-level X-lifts or lateral chamber fusions, and these are the hardest one. In the beginning, the companies told me, oh, for Scoli, this is brilliant. You have got large, and it works in the osteoporotic patients as well. And my first ones have been Scoli patients, And I had to say I did the same experiences like you did, and I switched then to the monosegmental XLIFs for a personal learning curve. And I think it's really helpful to start with the easy cases, monosegmental, no scoliosis, Bestus 3-4, like Jonathan Rasuli has told us 3 weeks ago in a session. And is XLIF one of your favorite surgeries now, or do you think, okay, I have to offer it, or what is your emotional experience with the lateral approach?
Yeah, so I look at I spend some time to look at the patient when it comes to the preoperative MRI. I find that many of them have, at least in where we are in Singapore, many of them come quite late. So they already come with quite a fair bit of central stenosis. So when the central stenosis is quite great, this indirect decompression may not be able to achieve the full decompression. And as a result of that, I find that maybe about 30% of my practice is still a regular direct decompression via T-lift. And then, and then of course, some of them come with both deformity problem together with a spinal stenosis issue. And then of course I will offer, particularly the 2 and 3 levels, I will offer a lateral lumbar, because single level, I think that by the time you insert the cage and you drop in the screws and you still want to do a decompression, so you have to prone the patient, then I think that takes quite a fair bit of time. It's maybe just better to just do it from a regular T-lift approach. Of course, if there is a deformity issue that we need to address, sometimes I will put in another tube on the other side to remove the other facet joint. That will give me a bit more mobility, such that the thing that this space can really go into lordosis when we do a good compression. So it really depends on the MRI picture. And of course, the more levels, I would tend to veer towards lateral surgery. Less levels, probably more towards direct decompression, T-lift. Yeah.
Okay. Thank you, Reuben. I heard you have another meeting at 7 o'clock. So
yes.
I say thank you very much for showing your cases. And we will. I will invite you again. And now I would love to switch to Dr. Rothenfluh from Oxford and ask him to share his screen. So Dr. Rothenfluh is professor in Oxford in UK, but he is in transition, and he became, I don't know, it's the 1st of July now, head of the spine surgery department in University of Lausanne here in Switzerland, which is the we may say best university hospital of Switzerland. And I'm very proud to have you here again as a speaker. And Dominique, I think you have to unmute yourself. Thank you very much, Alex, for joining us.
Thank you for the kind invitation and the introduction. Yeah, that's, however, still one of my cases. I'll be starting in Lausanne in about 2 weeks, so that's why the slide and the case was done in Oxford a few months ago. So that's why it's still branded as Oxford, but I've been there for almost 10 years, and will now transition back to my home country. So this is actually is a pediatric case, or started out as a pediatric case, and the patient was presented to me when he was 17 years old by one of my colleagues, to which he was referred because it then presented with a rather extensive deformity. So what we've tried is to work up and summarize a little bit the previous history, which is actually quite interesting, and there's already a few things that one can learn, because one of the takeaway points is really that in any sort of spine surgery, once you start fusing, then you've opened Pandora's box, and there's really no way back. And it often, what comes after really goes back to that first operation that was done. So this patient, at presentation, was 9 years old with what we call syndromic spinal deformity, but he didn't have any unifying diagnosis. There were a few things that were not normal about him: learning disability, Perthes hip, reduced visual acuity, and there was no name for that actual syndrome. He presented first actually at the age of 7 years, and then had a detethering because he also had a tethered cord at the age of 9. Then he was observed for about 4 years before having the first surgery, as he was quite young. That involved a lateral fixation with then magic rod being put in. A year later, he had a failure of the pelvic fixation. Then the pelvic fixation was removed and the construct was shortened. Then 2 years later, again, the magic rod was removed with the fusion to S1. Then we had a distal failure with rod fracture and subsequent infection, and then all implants were removed about 1 or 2 years later. And at that point, then the patient was referred and we saw him. So that's the X-ray about at the age of 7 years. What we can appreciate is this lumbar curve with, not by definition, a hemivertebra, but definitely a wedge-shaped vertebral body, which I think is about L4 there. But it still does have a pedicle on one side. As we'd expect in this age group, any kind of type of deformity like this will progress over time. So at 9 years, we see the progression. At that point, then I guess surgery was discussed, and that's why they did a CT scan. I only have a few actually sections here that shows it was L4, that wedge-shaped L4, a bit less so in the sagittal plane, but mostly in the coronal plane. At the age of 10, there was 9 to 10, 8 and 11 was further progression, now even involving a trunk shift. And at that point, it was decided to do a first surgery. As we can see in the X-ray, it was still reasonably flexible above, however, because it's a compensatory curve. However, the lumbar spine was already reasonably fixed because of the wedged vertebra. Then this surgery was done. And one can probably discuss quite a bit around this. I guess the idea was to reduce it from lateral and do sort of almost like a growth arrest, remove the end plates, but not completely the wedge-shaped vertebra, and fix it from lateral, and then put growing rods in to in order to avoid fusion, I guess, of the rest of the spine. And it's debatable whether that's a reasonable approach. I certainly wouldn't have done that at that point. I would have really focused on the driver of the deformity, which is the wedge-shaped vertebra, and would have probably treated it as a similar to actually a real hemivertebra, and resected it and corrected the lumbar spine with a short fusion in that young patient, and left the rest of the spine most likely quite untouched, because over time with growth they will essentially correct, and the compensatory curve will correct itself over time then. So what happened then is we had a sagittal plane deterioration with essentially then failure of the distal fixation, with there a fractured rod actually 2 fractured rods that you can see. One of the problems with the magic rods is in this setting is also that while they help us with controlling the coronal curve, it is actually kind of because of the distraction mechanism, a kyphosing construct. So that's why probably this presentation is not necessarily very surprising. What was done then, it was the distal fixation was removed, so removed the pelvic screws and let that be. That was done in 2017, about a bit more than 6 months post-op. Because the patient wasn't doing well, I guess. This was then converted to a fusion. So the magic rod's removed in the fusion with the exact same fusion levels. Again, the sagittal plane at that stage wasn't addressed. Was not so easy anymore because the patient already had a fusion mass where you would want to dial in most of the lordosis. That's where he had that lateral instrumentation. So you couldn't just easily do that. And at the age of 14, as we would probably mostly predict, is that there was a further sagittal plane deterioration with essentially then pull out of the screws and failure of the construct distally with rod fractures. He subsequently then developed infections and the whole implants were removed, and that's how he then presented, and that's where I met the patient for the first time. The CT
Dominique,
here.
may I,
Yeah.
may I ask you a question? We see
Sure.
these X-rays, and it's very clear that the problem is present. Can you tell us what about the soft tissue? Is there a huge defect? Have there been revision surgeries from the soft tissue?
Oh yeah, well, I mean, he's had what, about 4 or 5 procedures at that point. I mean, yeah, I mean, the soft tissues, they're not exactly virgin at that point anymore. And he had also he had infection about in 17 or so about 4 or 5 years ago. So soft tissue was not a problem as such that there would be breakdown of the skin or anything, not like that, but. Yeah, it was just heavily scarred. Yeah.
So it's not easy. I wonder what's going on now.
Yeah. So that's what I'd like to discuss. See if people have any opinions what they would do. That's what the CT scan looks like, and what we can see is that the compensatory curve is to some degree now fixed. I mean, it's not as bad as when he's standing, where he's clearly just falling forward. And that extensive curve that we see here in the AP is to some degree because the patient is actually falling forward. So we don't actually see an AP really of that spine. It is more like an AP from kind of oblique from above that we're looking at it, because he's falling forward so much, as we can see on the lateral X-ray. So when he's then supine, that to some degree corrects, but it is still very much a fixed deformity. The CT across that apex of the lumbar curve, which was really the initial driver of everything, shows that the L3 and the L4, that wedge, is fused in, and I guess that was intended with that surgery. So we have a fusion there. The rest of the spine, although there was some instrumentation in it, didn't show like really solid fusion, but it was still a fixed deformity. I don't know if people want to discuss, how they would approach this, what type of procedure, how they would plan, or whether I should just go to.
Dominique, can I ask?
Yeah.
Was the patient still able to walk at that point of time?
Yeah. Oh yeah, he's a walker.
Mm-hmm.
But as you can imagine, the gait is clearly altered because of that pelvic obliquity, first of all. Secondly, I mean, his hip joints are clearly an extension, so that doesn't necessarily allow for a normal gait. Yeah.
I look at the CT scan and I think that this patient, actually, I'm quite worried about the osteopenia when you need to do your second, whatever you want to do, because actually it looks like there is a bit of osteopenia going on. Was that the case?
No, not really. Screws had a good hold. I don't remember I measure the Hounsfield's unit. I don't rely on DEXA scans or anything. Even in my adult patients, I generally measure the Hounsfield units. If they're around 120 or above, then I don't usually worry about it. If they're below, but still in the range of 100, then I use HA coated screws. I don't cement anymore. But in this case, actually, I think I did use cemented HA coated screws here. I think I did use AJ coated screws here. Yeah. But you can see, you know, I mean, the pedicles, there have clearly been screws in there. So that was done without navigation. So putting screws in there wasn't exactly straightforward in that revision, in such a revision case. Yeah.
So, Dominic, can you tell us what are the angles? What kind of deformity do we have? How many degrees and in what plane?
Yeah, well, we have the lumbar curve at that point measured. Oh, I had the maybe have it in the solution slides. Don't remember. It was 60, 70 degrees in that order. That's what the lumbar curve was like. We cannot really get a reliable cob measurement for the thoracic curve, which is compensatory because of just it's not a true AP here. That will give us a false.
But when I got it right, you've had primary 6 years ago. There was a lumbar deformity, and now you have, when the patient is 17 years old, you have got a thoracolumbar deformity, fixed deformity with partial
biplanar
fusion.
Exactly. Yeah, fixed deformity with partial fusions about 5 surgeries before, and now a biplanar deformity. So, I mean, with the coronal deformity, he's reasonably balanced still. You know, if you try to kind of draw a CSVL as much as you can do, you know, kind of the head falls right in the middle of the sacrum, sort of. But in the sagittal plane, of course, that's a gross deformity, really, right? Gross sagittal deformity. So, you know, like, I don't worry about here any of the sagittal plane classifications, and so that's way beyond all that stuff. What you want to do, you know, is essentially restore a balance. That means that the head is essentially balanced over the pelvis and the femoral heads. That's really the main goal of that surgery, and that's how I approached it. It's almost like measuring, like in an Ang-Spon patient, almost measuring the whole body kyphosis angle, right? And that gives you then the approximate amount of correction that one needs. To some degree, taking into account that the pelvis will be retroverted, and ideally we would get some correction of the retroversion as well. But, you know, that will necessitate a rather large correction.
Okay, and the tethering, the tethered cord is solved the problem, or do you still have the problem of
No, that's
tethering?
solved, yeah.
Okay,
that's solved. Yeah. Yeah, but, you know, like, there is the option. There is no, like, if you try to find like a corridor where no one has ever been before, that doesn't exist, right? Had a lateral approach, had several posterior approaches, had fusion masses fused there, has had people have been in the canal from detethering the cord. So there is there's only like unattractive options. There's not really one that sticks out where you would.
From the principle, it's just a question whether when you do a deformity correction, whether you prefer shortening techniques, or do you think that vertebral resection and implant some kind of lengthening would be possible too? Or do you think that the principle of shortening the spine during deformity correction must be obeyed?
Well, that usually it usually comes down to shortening. You know, if you do a 3-column osteotomy, obviously in the VCR you can put in a cage and avoid the shortening, which is not necessarily what I would do here. No.
Okay. So the audience is listening. It's full of tension. What's your solution?
Yeah. So I simulated, and in order to get in order to balance the head over the pelvis, I need about a 35-degree correction. And when I then worked this out, it came down to essentially remobilizing and resecting from posterior that hemivertebra, which is now, or hemi-wedge-shaped vertebra, which is now fused to mostly the L3. Obviously, in order to do that, one needs to remove the lateral implant, so he needs to have another lateral approach, removing the implant, and then re-instrumenting the spine from the back, and then doing a 3-column osteotomy. Actually, it is something like a PSO, but a variation of a PSO. It's clearly asymmetric. It is something in between of a VCR and a PSO. So the amount of resection was more like a VCR, but I didn't resect the anterior wall and mobilize the anterior wall as you would normally do in a proper VCR. So it was kind of like a poor man's VCR, but more than just a regular PSO. Then allowing a biplanar correction. In terms of the coronal correction, what I generally do is I simulate this as well. You can hear it with SurgiMap, and I don't just rely on the angles, but I measure in millimeters, like how high and how I want to resect the vertebra, because that to me is more reliable than relying on the angle for a biplanar correction for so-called asymmetric PSO, because there's always a degree of coupled correction. So you cannot just correct one plane independently of the other. There is always the coronal correction will affect the sagittal plane and vice versa. And those two have to be balanced. And that's why I like to, when I do the planning, I actually like to measure the distance between the two, especially in the back, where I then use the osteotome to know like how far the osteotomes need to be apart and how high my posterior wall of the wedge that I take out has to be. So that's how I planned this. It came down to about a 35 to 40 degree correction. That's about as precise as we get. And I figured that if I can take out that wedge, then it would result into also an adequate coronal correction. So my goal was to achieve a coronal and sagittal balance. It required a lateral implant removal, then posterior instrumentation, and then we did the osteotomy in a second sitting, just to reduce the surgical hit on it. And our anesthetist, they calculate the transfusion trigger before we do the surgery. So we have a transfusion technician in the operating theater all the time for complex pediatric and also complex adult and tumor cases. And the transfusion trigger was clearly such that if we did, including the 3-column osteotomy, then the blood loss probably would have been too much, such that we said what we're going to do it in a second stage. And then the planning, it was really that this wedge trapezoid-shaped vertebra had to be resected to get an adequate correction. So that's what we did. As you can see, it resulted in a rather dramatic sagittal plane correction. We only got the partial correction, of course, of the upper compensatory curve. So I wasn't necessarily expecting a completely straight spine here. Essentially all correction was done in the lumbar spine. That short rod really helped me then close down after the resection. But the most important goal was really the coronal and sagittal balance, which we have achieved, and that's the X-ray 3 months post-op. We still have the only thing that I'm a bit disappointed about is I knew that the rest of the spine will be reasonably stiff because we saw that already in the X-ray, so we jacked it out as much as we could. What I would have hoped is a bit more correction of the pelvic tilt, so correction of the retroversion. While his gait has a bit improved, it's still retroverted, and the hip joint has really reached its limit of range of motion in terms of extension. So, which clearly can affect the
Well,
gait.
Dominique, this looks amazing good. What a change for the boy's life. It is really dramatic. But do you think that
first
the
time in
pelvis
10
is...
years he was able to stand upright, pretty much, almost, or about 7 years,
Yeah, it's in retrospect maybe 6 lost years, but it's always so hard to do retrospect analysis because these deformities really a challenge. May I ask you your comment about the pelvic incident? Do you think this pelvis is has no dysplasia? Do you have the same rules in measurement in these patients like in a normal adult? Because I don't rely on the same measurement in these bony dysplastic patients.
I mean, well, the angles are defined, whether the principles that the pelvic incidence necessarily needs to match the lordosis is true. That's a different story. Because the sacral slope is actually the more important predictor of the lumbar lordosis than the pelvic incidence. The pelvic incidence is essentially a proxy of the sacral slope, and mostly matters if we can restore the version of the pelvis, which we here couldn't. As I said, the retroversion mainly has an impact on the range of motion and the function of the hip joint here and the gait, Other than that, the main goal was really to rebalance the patient, to rebalance the trunk and the head, such that he can essentially stand.
You managed
the measurements of the angles are essentially the same, but I didn't rely so much on it. You cannot get, it's so abnormal. You cannot reliably define a sacral end plate very well to get a reliable pelvic incidence measurement, maybe in the CT scan. So for my planning, I didn't focus very much on the pelvic incidence, but mostly looked at the whole body kyphosis angle and how much correction will I need to essentially get the trunk back over the pelvis.
Wow. Dominique, this is such a beautiful change. Can you comment on your rod construct? You have hooks in the thoracic and because of the fusion mouth, I remember I've seen. Do you love the hooks on top ending, or is this just because it was the easiest, the safest way?
No, I don't generally use hooks. That was my pediatric colleague who asked me to do this case with him. He did the reinstrumentation essentially. I personally try to avoid using hooks. I don't like it so much. I don't. People use it as also as a sort of like soft landing. There's such a heterogeneity in the literature where there, and so many approaches that allegedly seem to prevent junctional kyphosis, but none of them really do. That's just because it's a multifactorial problem, and there's just not one solution that fits all. So I think that the reason why screws were put there, and I mean. Lamina and pedicle hooks were placed there is because there was essentially no landmark for a pedicle screw at that level, and we don't use navigation. So if one had navigation, certainly, I mean, I would have instrumented that with screws.
So thank you very much. Thank you, Dominique. This is an amazing case. I wonder how many surgeons are here in Switzerland who would achieve the same result. And I'm happy that you transitioned to Lausanne, to Switzerland. Then I know where I have to send my youngest patients to. Thank you very much.
Thanks.
Thank you, Dr. So from Singapore. And I just wanted to announce next week's speaker. This is from Geisinger Institute in Pennsylvania. It's Dr. Concardala. He's talking about endoscopic thoracic spine applications. And I just want to thank you all for listening and watching our conference. Dominique, see you soon in Switzerland.
Absolutely.
Thank you very much. Thank you, Dr. So, and thank you all for listening, and goodbye. Have a nice evening. Thank you very much.
Thanks for